Hi, this is my presentation on the effects of unilateral real-time biofeedback on propulsive forces during gait. So the purpose of the study was to determine the effects that biofeedback during gait training with increasing anteriorly directed ground reaction force would have on a target leg. 7 individuals were assessed by having them walk at a normal speed on a dual belt treadmill assisted with force platforms. During the gait training, the individuals were given real-time AGRF biofeedback that encouraged a 20 to 30% increase in peak AGRF by their targeted leg. The results found that when comparing anteriorly directed ground reaction forces generated during the pre-training gait trials versus during and immediately after training, there was a significant increase of AGRF in the target leg. These results resulted in the demonstration of short-term effects of using unilateral AGRF biofeedback to target propulsion in a specific leg. So the problem, after a stroke, individuals with hemiparesis experience a smaller push-off force generation in the peritic leg during the terminal stance phase. This negatively affects their gait speed, interlimb symmetry, and walking function. In this study, unilateral anteriorly directed ground reaction force biofeedback is being tested because it can enhance the patient's awareness of the impairment targeted during a gait training session. So this study's hypothesis is that in just one session of unilateral AGRF, biofeedback would lead to increased AGRF production in the targeted leg without increasing AGRF production in the contralateral leg. And although in previous investigations, biofeedback was able to increase push-off bilaterally, I agree with this hypothesis and believe with the correct methods that it is possible to increase AGRF production in a targeted leg and not in the contralateral leg. Methods. So 7 right leg dominant individuals were assessed at a speed they selected as their normal walking speed. All gait tests and gait training was performed at this speed that they self-selected. These participants walked on a dual belt instrumented treadmill with force platforms underneath each belt. Each foot was placed on each belt to set the legs' GRF data apart from each other. The participants underwent a 15-second walking trial that collected their average peak AGRF produced by the right leg over 10 gait cycles. Propulsive force generation was captured with peak AGRF, so the feedback variable could be calculated quickly and accurately. During training, auditory and visual biofeedback was provided via a display screen and speaker. The visual feedback consisted of a line graph that showed the current measured value of anterior-posterior ground reaction force. A target line on the graph represented the targeted peak AGRF. The auditory feedback consisted of a beeping noise every time the participant being tested reached the targeted peak ground reaction force value. Gait training was comprised of 11 minutes of walking continuously on the treadmill, and the baseline values of each individual's peak AGRF were taken within the first 30 seconds. The next 10.5 minutes consisted of real-time visual and auditory biofeedback that encouraged these participants to increase their peak AGRF of their targeted leg 20 to 30% above the baseline peak AGRF recorded in the first 30 seconds. After completing 11 minutes of biofeedback gait training, a 2-minute break was given before 2 retention tests were performed. The retention 1 normal gait tested the participants by having them walk normally for 30 seconds. Next, the retention 1 replicate gait had the participants try and modify their gait to match the walking pattern during the biofeedback training as much as possible. These 2 tests determined whether the participants could demonstrate recall of the previous gait pattern and tell the difference between their normal and replicate gait. Here are the variables of this study. So there was the primary dependent variable of which was the peak anteriorly directed ground reaction force from the right leg. This study also had a secondary dependent variable, or a few of them, which included the timing of the peak AGRF generation with respect to the stance phase, the steps per minute, the stride duration, stance duration, and swing duration, and also the peak vertical ground reaction force. These variables were all evaluated at 3 different times: the pre-training, post-1, and retention 2 replicate gait. The independent variable of this study was the auditory and visual biofeedback. Okay. The results concluded that there was increases in anteriorly directed GRFs for the target leg during the propulsive phase of the gait cell during biofeedback training compared to pre-training. Although there was no difference in peak AGRF production between pre-training and retention 1 normal gait or retention 2 normal gait, the non-targeted leg showed no significant effect of biofeedback over time on peak AGRF production. The study also resulted in no overall effect of biofeedback over time on coefficient of variance of peak AGRF production in the targeted leg. Surprisingly, there was a significant overall effect of the time on the non-targeted leg, but there was no statistical differences found in the CB. Error was found in achieving targeted peak AGRF during and after biofeedback training because the participants had a tendency to overshoot the target AGRF during training. When looking at the results of the secondary gait variables, we found that there was no significant difference in timing of peak AGRF, right peak vertical GRF at post 1 or retention, or no significant differences in left stance duration at post 1 and retention 2. However, it was found that the left peak vertical GRF was significantly greater at post 1 as well as at retention 2. The cadence of the right limb showed a reduction at post 1 and retention 2 replicate gait, while the cadence of the left limb was significantly smaller at post 1 and retention 2. The right stance duration showed a significant increase at post 1 and retention 2, along with right swing duration and left swing duration. Okay, in this figure, we can compare the peak AGRF in the right versus the left leg, and we can point out the differences in increasing, decreasing, and no significant differences in the AGRFs between the targeted and non-targeted leg. In figure 3A, which is this one up here, we can compare the targeted leg versus the non-targeted legs coefficient of variance and notice how the left leg showed a larger effect. In figure 3B here, we are given the average RMSE and the percent error for peak AGRFs for the right leg during different times in the experiment. And then this last figure of it shows all the results of the different secondary gait variables in the study. You can see all their increases or decreases. So after interpreting these results, we can discuss what may be done in the future to further the studies of peak AGRF production in the targeted legs, such as elucidating the change in ankle, knee, and hip kinematics that contribute to increased peak AGRF. We can determine if unilateral AGRF feedback is effective at increasing AGRF production in the parotid leg of individuals with unilateral gait deficits, such as post-stroke hemiparesis. And we can also determine how the training structure, schedule, doses of magnitude of targeted peak AGRF and type of biofeedback influence motor learning during gait training. And then for the critique, do I agree with the author's interpretation? Yes, I do. But I would suggest performing this experiment at different times. So like instead of doing only 11 minutes, why don't you start with 4 minutes and perform the retention test, then gradually increase the amount of minutes for the gait training, because this could allow for the participants to understand the replication of the peak AGRF during the retention tests better and possibly leave the study with better results. One follow-up experiment I would suggest is having the same individuals come back and have them try and replicate their peak AGRF the next day to see how much of a decline in repetition the participants would have. And so this could help the authors predict how many times someone who is post-stroke with hemiparesis may need to practice the skill to get back to their original full propulsion force. And yeah, that's it. Thank you.